All right. Hi, everyone. I'm going to go ahead and get started. This, for me, is probably one of the rougher talks to put together, just because I think when you go through the data, they like to show one slide and say, yes, and now we have this therapy for IPF, but I think there's a little more to it, and this has sort of been something we've been asked more about the last couple of months, as 2 drugs have been approved in the last now 3 months. All right, so I do have a financial disclosure. I do receive honorarium for doing IPF disease education and awareness talks. They're non-branded. I'm not allowed to mention drugs of that, which is the way I prefer to do a talk. All right, so case scenarios, and actually these are all based on things that we've been, either Jeff Jennings or I have been asked about in the last several months, as we knew that the drugs were going to likely be approved. So that actually happened during Javier's grand rounds, and I got yesterday, people were not happy with me. I tried to do not disturb it, so I understand. It's okay. I don't know. So 75-year-old male, prior history of tobacco use, heavy alcohol use in the past, who had progressive IPF with progressive shortness of breath and hypoxia. He had been actually lost to follow-up for 3 years and then kind of showed up to the provider that sees him. His FVC at that time was 55% of predicted. He had a DLCO of 35% of predicted, and both had decreased by 15% at least compared to 3 years prior. So he had actually been admitted a few months prior to this for presumed IPF exacerbation. So the next one, one of the other ones we were asked about, so again, also in the mid-70s, former smoker, dyspnea on exertion for 2 years, which had significantly increased from the year prior. I'm sorry, I just copied it out of some of my notes. The patient had hypoxia, pulmonary hypertension, and PFT showed an FVC of 70% and a DLCO of 28%. Why I keep mentioning those are because most of the trials there, inclusion-exclusion criteria are based heavily on where the PFTs are. So another subset of patients we've been seeing lately are the patients with some kind of liver disease or actual cirrhosis. So there's one that I recently saw with Rodeo, who is a never smoker. He has a history of cirrhosis. He's actually going to be listed for liver transplant. He didn't have any dyspnea. This was an incidental finding, apparently. And so he was noted to have ILD. He actually underwent biopsy and has usual interstitial pneumonia. So he has a clinical diagnosis of IPF. His FVC is 65% of predicted, DLCOs in the mid-40s. The next is also a patient sent from an outside facility for IPF therapy evaluation. He had UIP on biopsy, but in talking with the patient, he actually still is actively taking care of a farm. He spends more than a few hours there every week. There's horses there. He deals with the hay. He feeds, he works with the horses and deals with hay there. So he actually had a fairly well-preserved FVC of 72% and a DLCO of 56%. And then the one I've seen recently was a gentleman who was diagnosed with peripheral vascular disease recently. He drinks daily, who had possible UIP on chest CT. And so he was given a clinical diagnosis of IPF based on his lack of underlying diagnosis, and that he had all the features except for honeycombing on high-res CT based on new data that I'm not going to spend a lot of time going through. And he, again, well-preserved FVC and a DLCO of 60%. And then the last one is a patient that actually Dr. DeGiovanni sent me, who is a never smoker. She has reflux with progressive dyspnea and cough. She has a clinical diagnosis after IPF after surgical lung biopsy, and her FVC is 95% and a DLCO of 68%. So I think it's easy to kind of look at these or hear that you know that you have a patient who has IPF and think, okay, so I'm gonna treat them. Okay, now what do I do? And so I wanted to go through the things that I've looked at for how to decide who we should be talking about therapy more seriously with, and who could be candidates for research transplant as well. Okay, so what we know is that IPF has a variable, difficult to predict course. So we're hoping that most of our patients end up in this range, but most of the studies will exclude patients who have had a diagnosis less than 6 months for their IPF because they're worried about this subset of patients, the patients with rapid progression. And then in terms of our understanding, it's probably not just a slow progression for most patients. There's slow progression with an acute exacerbation. You don't reach that baseline, that prior baseline again, and that's your new baseline, and you decline from there until you have maybe another acute exacerbation. So from a lot of negative trials that we have, negative studies in terms of therapeutic trials, we know that the average rate of decline is about 200 milliliters per year on average, and that's an absolute value. I will highlight that again. Remember that number because it'll come up again. Okay. So in terms of, just so we're on the same page, the high-risk CT criteria for UIP pattern, hopefully this is review, subpleural, basilar predominant, reticular abnormalities, honeycombing with or without traction bronchiectasis, and then absence of inconsistent features, which would be a lot of ground glass, extensive ground glass, a lot of cysts that are not honeycombing, and upper lung, mid-lung predominance. So, and then possible UIP, which is now this subset that we're thinking probably doesn't need biopsy anymore. And this is a change based on retrospective data from a study looking at ambrisentan in patients with IPF, which is a negative study. But what they did was look at patients who underwent biopsy for possible UIP, and 94%, there was a 94, actually, if you have this pattern, 94% predictive value of actually having UIP on surgical lung biopsy. So we're probably going to be moving away from biopsying some of these patients that are just missing the honeycombing. Okay, so the first two, better for definite, what we should say definite when we're talking about radiographic patterns, definite UIP, and then possible UIP. And this is the subset that now we may be moving away from having to biopsy. Again, good, has to have good story, no underlying illness. Everything else fits for IPF as well. Okay, so so the only change in that diagnostic algorithm, the new one that came out in 2011, is that now we are probably going to be adding in possible UIP because, again, there's a 94% positive predictive value of actually having IPF if you have that pattern. I actually think that, I wish they kind of redo this. I think that the multidisciplinary conference can actually come in sooner here. I think having a chest radiologist review your CT to ensure that that we're actually calling the pattern the appropriate thing, I think would be helpful in terms of getting people to the right diagnosis. All right, and so some of this, again, is probably repetition, and that's okay. And if it's not, I'm doing something wrong. So again, looking at why we use the multidisciplinary conference is that when we incorporate and have discussion between the radiologist, an academically trained chest radiologist, and still in academia, clinician, and pathologists, and have that discussion, yeah, we have a consensus. But I actually think the more important data here is that of about 20, this actually represents about 20% of the patients actually had a change in diagnosis based on this conference. And so this is not something we can do in, I think we can do well in isolation, that we do need the help of our radiologists and pathologists, and actually having people together to have that discussion is helpful. Okay, put that one in again. And so there are a lot of therapeutic targets on here. Almost all of them look at some form of, all of them look at some area of fibrosis. And the ones that we're going to be looking at, the ones that are approved, are nintedanib and pirfenidone. But pirfenidone's thought to work, and nintedanib, in a couple different areas when we're looking at sort of pathogenesis of IPF. Okay, so let's talk about nintedanib. I'm not sure how they come up with the brand name, but the other name for it is Ofev, which I don't think either name is very easy to say or easy to remember. I was calling it Nintendo for a long time. So the mechanism of action is it's a triple tyrosine kinase inhibitor. So VEGF receptor, fibroblast growth factor, and PDGF. So all three pathways are implicated in fibrosis. So if you block all three, hopefully you are able to block fibrosis. Both medications we'll talk about do involve liver clearance. So patients do have to have good liver function. Okay, so based on their phase 2 data that they had that was published in the New England Journal of Medicine, this led to the phase 3 trials. But basically it showed in the phase 2 that patients who were receiving nintedanib over placebo had less decline in their FVC. And here they actually had to work out quite a bit. And we were not a site for this study, but I did go to the investigator meeting before we decided we were only doing one study. The half of the time what was talked about was the diarrhea, because it was a huge limiting factor in that phase 2 trial. So they were as the trial was getting started, they were working through how to deal with that. And they've actually come up with a very nice protocol which makes it a little bit more user-friendly for the patient and for clinicians. Okay, so the phase 3 trial that was published in May, and what we're basing the FDA approval, what the FDA approval was based on, looks at 52 weeks of treatment with placebo versus nintedanib, and they would follow the patients for about almost 30 days afterward. And their primary outcome is annual rate of decline in FVC. Okay, so in looking at their inclusion criteria, patients had to be at least 40. They had IPF diagnosis within 5 years of visit 2 is when you're actually, past the screening, you've been randomized. That they've had a CAT scan in the last 12 months, and that that they have a diagnosis of IPF based on really the new ATS guidelines. Patients could have as low of a DLCO of 30% of predicted, so they did include patients that were severe. If you look at, we do have a subset that patients have preserved FVC but a low DLCO. Under 30%, there's a much higher incidence of pulmonary hypertension, so the cutoff that's used in both studies is 30%, and an FVC of over 50%, and this is thought to be the mild to moderate group of IPF patients. Okay, so what's interesting about this study is that they, and I think some of it is because the investigators that were involved in the Artemis study, that ambrisentan study, were also involved in creation of this study. So they actually had knowledge of that change that was going to come in terms of patients not having to have definite UIP on chest CT to not need a biopsy. So patients could have all the other features except for honeycombing, and that could be enough. They could get into the study without a biopsy. And so that's a major difference between the nintedanib and the pirfenidone studies. And then if there's surgical biopsy present, they would have to meet IPF criteria based on what we're looking for on pathology. And so this is central review, both studies central review. Okay. Lots of exclusion criteria, but major ones would be pre-existing liver disease. If you had a considerable amount of airways disease, here they don't define it. I'll try to compare as we go along to pirfenidone. In pirfenidone, they actually have a defined cutoff. And then for this, they said that it was okay that you were listed for transplant, but you couldn't be expected to have undergo lung transplantation in the next 12 months. So these are the patients who maybe aren't hypoxic at all yet, but are being worked up and evaluated for lung transplant, are going to be listed at some point. The other big area of exclusion is related to cardiac disease and then thrombotic and bleeding issues. So because it does block those 3 pathways, there may be an increase. Bruno, were you asking or you're stretching? Sorry.
No. So the concern about lung transplantation, was that just in their study because they didn't want the confounding, or would you be worried about having a patient on nintedanib
I think it was
go for transplant?
No, I think it was to keep, because as soon as they went for transplant, they go off the drug. So it was just so that they would have more data to deal with. Thank you. Okay, so anyway, so there may be increased risk of vascular thrombotic events on this medication. So they actually excluded patients who had more active or recent cardiac disease. And then if patients were on some type of anticoagulation or antiplatelet agent, they had a higher risk of bleeding events, so you cannot be on that and nintedanib. And more than aspirin as an antiplatelet. Okay. All right. And then other general exclusion, and this is pretty similar in the two studies. You can't be on more than prednisone 15 per day. You have to be on a stable dose if you're on prednisone, and you could not be on another investigational drug. This is going to change for IPF studies in the future because they have to account for patients being on either nintedanib or pirfenidone. Okay, so this part I need help with. I had a hard time, and especially with the pirfenidone one, I had a much harder time understanding that. But this one they were looking at, based on their phase 2, this one I thought made a little more sense. Based on their phase 2 data, they were expecting a difference in 100 mLs in the annual rate of decline, which is not a whole lot, I know. But anyways, if we're thinking that patients lose 200 mLs a year, you're cutting that rate in half potentially, is one way to look at it, or at least hopefully stabilizing. So standard. So basically they were assuming they would lose about 2% of patient data. So they had a goal of enrolling 194 in the placebo and 291 in the nintedanib arm.
So that 100 was an arbitrary number. So
No. That was actually based on the phase 2 data. That was the difference that they saw.
Okay, so 100 mLs, what we can consider
Over a year. Yeah.
Over a year.
Yeah.
So is there any data that tells us what's a clinically significant change in FVC for IPF?
Well, what we know is that it's a 10% drop in FVC. So you would have to have, yeah. So it's the 200 mLs could get up there for some of the more severe patients, but for someone who has, still has an FVC in the 2.5 liter range, that's not 10% to drop 100 or 200 for the year. Okay, so the other thing that's so what they did with their missing data, and remember this when we talk about the pirfenidone, is that if the patient discontinued the drug, they still followed the patient. They still got their FVC, and unless the patient absolutely refused. And they used that FVC, because it's intention to treat, whether the patient was still taking the drug or not, they used that FVC for their primary analysis. And then they said, and I don't understand this, and if someone can explain it to me, that's great, but their statistical analysis allowed for random missing data. Bruno?
Yeah, I'm not sure I know.
I'm not sure what I mean. That's, again, the extent of, that was the in detail that they give you.
There are different ways of, basically when you have missing data, you can't assume that the people for whom you don't have data are exactly the same as the people for you. And so there are a variety of statistical ways of trying to deal with that. I think that's the best I'm going to do. If Leo was here, he'd do better.
Okay, so we'll look at the baseline characteristics in patients. So most of the patients were in their mid-60s, mostly male. And this goes along with when we're sort of probably our highest time for diagnosing patients. Smoking status, most were smokers, former smokers, about 70%, sort of across the board, maybe a little bit lower in the impulses, but probably impulses too, but probably not significantly different. About a fifth of them, and again, they were using academic practices, large private practices. About a fifth of the patients were on systemic corticosteroids. And then looking at the FVC averages, I think it's easier if they actually listed the percentage, but in terms of raw values, actually this is not terrible. This is fairly well preserved. So again, that mild to moderate category. And then the DLCO, really again, because they weren't including anybody under 30%, I think that we knew the average was going to be a little bit higher. So almost 50% across the board. Okay, and this is not blurry because I can't copy it. It is blurry in the PDF of the appendix. So I thought it was interesting that they chose to not put these in the actual article that's published online. That this is just in the appendix. But basically, for impulses 1 and 2, it shows that they actually had very good follow-up for these patients. They didn't really lose a lot of the patients. Okay, same thing with impulses 2. Okay, so looking at their primary endpoint, which again was decline in FVC over the year. So the nintedanib group had a better preservation of FVC than the placebo group did. So when you look at the nintedanib, so it's about 100, and then in the placebo arm, which is in line with what other studies of IPF patients in the placebo arm have showed, that about 200 mLs. And then when they look at the mean percentage change, there's some argument and there's some data that definitely 10% drop is, a 10% decline is significant. There may be even some significance as low as 5% change in FVC. So those are the two things that they kind of want us to get out of this, and I do think that they show it well in both of their studies, but they planned a pooled data analysis, unlike with the prior pirfenidone studies where they didn't have a planned pooled analysis, they just kind of pooled them. So when you look at patients who were responders, so patients who didn't have a decline in their FVC of more than either 5% or 10%, they looked at both, that was also higher in the nintedanib group. And so they actually they're looking at slope of change as sort of what should be significance, and they go through what their covariates are. So I think that when you look at an absolute FVC drop, you probably should know where that is in context of what someone's predicted is and how much that would, how much their sex and age would affect that as well. Okay, so another way of showing some of this data, so the Impulsus 1 and Impulsus 2, so the two trials that were running simultaneously. Again, you see in the nintedanib group lower loss of FVC over the years worth of being on the drug, and I think this kind of shows it nicely, the difference in the two groups in terms of mean change in FVC. And so the darker lines and all of these in the blue boxes are nintedanib. Gray is placebo, and gray here is placebo as well. So they also wanted to look at acute exacerbations. The next slide has the definition of that. And here they did not have a significant difference in both. So they actually don't claim this as something that the drug necessarily does. It's unclear if it does it or not, is how I would put it. So in Impulsus 1, and this is the issue that the pirfenidone group ran into in the older trials that they had, that one showed a significant, the other didn't, but that was for their primary outcome. This is just one of the secondary outcomes. So they're looking at acute exacerbation, so no difference in Impulsus 1, and then a lower rate of acute exacerbation in the nintedanib group in Impulsus 2 with this significant p-value. So when and how they explain this, and I actually think it's good that they had a couple different ways of breaking this down. They actually looked at it as a combined, if the site had called it an acute exacerbation, and if on central review they still thought it was an acute exacerbation. So if any investigator thought it was an acute exacerbation, and that could be, again, they saw lobar infiltrate, and they called it an acute exacerbation, which you should not if you're going by the sort of strict criteria, they still counted it. And so that might play into why some of their data, it wasn't significant, but again, it's unclear. Okay, so in terms of what sort of the accepted definition, although we still call it the proposed diagnostic criteria of an acute exacerbation, is that a patient has a known or is presenting diagnosis of IPF. They have unexplained worsening or development of dyspnea within the past month. They have new bilateral ground glass opacities and or consolidation superimposed on their background of UIP on the high-res CT. And they don't have evidence of pulmonary infection, and they don't have alternative causes. So they don't have heart failure, they don't have a PE, they don't have an identifiable cause of acute lung injury. So if somebody has IPF and comes in with pancreatitis and ARDS, it's ARDS, it's not an acute exacerbation. Okay, so when they looked at their, they had some secondary lung function endpoints at week 52. So again, this is this 5 and 10%, and it's just kind of showing it in a slightly different way. But again, they consistently, through looking at all of these, did show a difference between the nintedanib and the placebo group. And across the board, their numbers for this is pretty consistent. Okay. Adverse events. Okay, so there's a lot of talk about the diarrhea. So less than 5% of the patients actually had to stop the drug for diarrhea. So what they ended up doing for a lot of the patients is they would try dose reduction, and then if that didn't work, they would stop the drug for a week to 2 weeks, and then they would restart the drug. And even if they went back to the same dose, a lot of the patients could stay on that medication. So it's unclear why exactly it wouldn't come back, but patients could tolerate going on that. And so now when I have material that they're giving with, when trying to prescribe nintedanib, they actually have a protocol for the patients to kind of follow with the Imodium. They have a support line. They've gone through a lot in terms of the adverse events. The one of concern, and I think I have it as, I'm not sure if I have a separate slide or not, is the cardiac adverse events. So when you compare the nintedanib group, if I can get the arrow to show up, the nintedanib group and the placebo group, there was in one of these studies actually a higher rate of adverse cardiac events. I have to find it though, I'm sorry. Let me see if I have it in here. Fatal adverse events. Okay, yeah, no, it is higher, although the percentages are almost identical. So there was a lot of concern raised, and when you hear folks who see a lot of IPF, their concern with the drug is that are they going to give someone an increased risk of cardiac decompensation or having an MI? We don't actually have any kind of data on that specifically for pirfenidone. But again, with the pathways being blocked, it is a potential. Okay, so I'll do some summary on that in a little bit, but we'll walk through pirfenidone or Esbriet, which has a lot more name recognition and probably a lot more comfort because people have been prescribing it in the trial, and if they were involved in either trial, either of the two large trials, they are probably more comfortable with this medication. And they have much better PR and marketing than I guess BI does. All right, but anyway, so pirfenidone, the mechanism of action, it's an antifibrotic. The mechanism is unclear. It acts in a few different areas, but it's basically just found to block fibrosis. Okay, so there was the capacity, which we'll go through very briefly, the phase 2 and 3, that had some conflicting results. The primary endpoint in capacity was the % change in FVC over 52 weeks. So similar to what the nintedanib study looked at, and they didn't meet statistical significance unless you try to pool the data, and this is why the FDA asked for more data. So in those studies, this is the part of capacity, or the 004 and 006 studies. Their baseline characteristics were actually pretty similar, and in terms of looking at how it compares to the pirfenidone group, most of them men, most of them in their 60s, about, I think it was 70% in the nintedanib study. Here it's about 65% were former smokers, and then the average FVC was actually fairly well preserved in the 70s, mid-70s range, and the DLCO again in the mid-40s range. Okay, so there wasn't a consistent improvement in FVC. So this is the background leading up to the more recently published data. So capacity is the old stuff, ascend is the new. So capacity, unless you pooled it, there actually wasn't a significant difference in FVC, not improvement, I should say preservation over placebo. And this is the second study that they were doing simultaneously, didn't show a significant difference. But again, if you pool it, and that was the argument they were making, but it wasn't a planned analysis. So that's part of why the FDA first initially rejected or asked for more data. Okay, so the study that was published in May is a phase 3, also double-blind, placebo-controlled, randomized trial. And this one also looks at 52 weeks, which is interesting because the capacity studies look at a longer time point. And here they would also follow up for up to 28 days after stopping the drug. So their inclusion criteria, they had to be diagnosed anywhere from 6 months to 2 years prior. So the patients had in the nintedanib study, they could go back to about 5 years past diagnosis to be treated or to be in the study. 40 to 80 years old, they did have an upper limit of cutoff for the age. High-res CT within 3 months. The other study was a year. And here the FVC criteria and the DLCO are similar, although they have an upper limit cutoff for the FVC, which the nintedanib study doesn't. Here they wanted patients that had some functional status, so patients who were able to walk because it was one of the endpoints they wanted to follow. And then in terms of exclusion criteria, if they had recent significant worsening, they said, again, this is one where they were a little less, they came along later. They would say if they were on the lung transplant list, we prefer that they don't be in the study. Later on, they went back and said, it's okay if we don't think they're going to be transplanted soon. It's hard to sort of judge that, where that should be. Active infection, and then if they had some other severe illness that you would expect them to pass away in the next 2 years, or severe hepatic impairment. So the endpoints they looked at, again, 10% decline in FVC. Here they added, compared to the older studies that they added in the endpoint of death, so either one. And then their secondary endpoints, they looked at change in 6-minute walk distance. It's thought in IPF that a change of 50 meters is the minimally important difference. Looked at progression-free survival, so either you had to have preservation of your FVC or preservation in your 6-minute walk test, or you had to be alive. And then change in, they used a different dyspnea scale. They used the UCSD dyspnea scale. Rate of any cause of death by central review, and then rate of IPF-related death, and that's also central review. The inclusion criteria on this one was a little bit more strict, I think because there was concerns that in the capacity, the older studies, that they maybe included patients that didn't actually have IPF, or that maybe they put in some other subset of patients. So here you had to have definite UIP. It wasn't okay just to have possible UIP. And even if you had possible UIP and a clinical diagnosis of IPF based on your surgical lung biopsy, a lot of those patients got rejected. Okay. This I think that is there's some voodoo involved here, and I'm not sure what goes on here, but so they talk about a ranked ANCOVA, and so they talk about the change in % predicted FVC from baseline to week 52. And then when I get to the missing data, maybe this fills in some gaps. So they looked at the standardized rank baseline value as a covariate. They had 2 planned interim analyses, and then in terms of looking at treatment effect, they looked at the drop in % predicted FVC by more than 10% or death. And so how they handled missing data is very different from how the other study we were talking about handled it. So if there was a death, the FVC would be carried forward as 0. So to me that almost seems like you count it twice. That if you're looking at average change in FVC, you're counting the patient as death, and then you're counting against that whole group again because there's no lung function left. And then death was given a worse rank, and for the patients, and early death was given a worse rank than later death, which doesn't really make sense to me because early death might not be reflective of the medication. Maybe you've not had enough time on the medication. So I might have done this I would have done it opposite, but this is how they dealt with it. And then other missing values, they would sort of assume the best case scenario, that patients had, they would take the average of the 3 with the lowest or smallest sum of squared differences. So basically they're assuming the smallest change of what they had to measure, and they were assigning that to missing values. So a little bit different way of dealing with data, and I think they carried forward stuff a little bit because of that. All right, so when you look at the enrollment and the outcomes, this is probably my not copying this well if it's not showing up well, but they actually did not have a lot of dropout either. They were able to account for most of their studies. They had, in the treatment arm, they had 55 that discontinued treatment and 39 in the placebo arm. Okay, so baseline characteristics in this study, pretty similar to the capacity and the nintedanib studies. So we look at we're talking about the age and the capacity study. So here it's also in the mid-upper 60s. Most of them are men, and fairly well-preserved lung function. And actually, I was surprised at how good the 6-minute walk distance was. And then here, when you look at patients who had a definite pattern of UIP, almost all of the patients had definite UIP, and they really did not include a lot of patients that had possible UIP pattern. And it's interesting, it's still, even when patients had definite UIP pattern, there's still 31% of them that still underwent biopsy. So we still probably have some range in what we're doing in terms of practice. All right, so there really wasn't a significant difference in mortality unless you take the ASCEND and pool it with the capacity trials. And I'm not sure if this was a planned analysis. I think when they were going forward with the ASCEND, which is the more recent one, I do think they put it in. I don't think they put it in for the capacity though. So the rate of death in the new study doesn't actually show any significant difference between pirfenidone and placebo. When you look at decline or death, they show it in a couple different ways. So here they're looking at that composite endpoint of either you had a decrease in your FVC or you died. And so the dark blue is the pirfenidone and the lighter blue is placebo. So higher percentage is worse because you either progressed or the patient progressed or passed away. And so they actually had areas they were looking at interim analysis, they were looking at different endpoints, but really the endpoint that they were saying they powered for was at 52 weeks. And so that's where they do show a significant difference between the placebo and the pirfenidone, but only when you include the decrease in FVC plus and or death. When you look at change in FVC, there was less change in the pirfenidone group compared to the placebo group. We're going to talk a little bit more about that one. And then in terms of walk distance, change in walk distance or death at the 52-week mark, that also supports pirfenidone over placebo. And then in terms of looking at progression-free survival, and that's that composite of either there was death, there was decline in FVC, there was decline in DLCO, that there was a significant difference. But really the major endpoint here, the primary outcome was this. Okay, so when they show this either significant decline or death, this is the 52-week data. And so, wow, that's a great p-value. So I don't know that I would have said, I mean, it looks very nice to say it like this, but I don't know that I would have said it was 132% increase. I think when I look at it, I see that, again, less patients receiving pirfenidone had a progression in their FVC by a significant amount, because we know that actually correlates with mortality in IPF, or actually didn't die. So less patients were dying in that group. So about 15% versus 32%. Okay. Then they talk about, and here's where they kind of lost me. I went back and read it a bunch of times. And so it's different than, it took me a long time to figure out it was different from what other studies had done. So what they did, and I don't know why it would be different. So they look at the mean absolute FVC decline, which is how the other studies that we based that 200 ml average loss on, how they did it. They just looked at absolute change in a year. So when they looked at mean absolute decline, so in the pirfenidone group, it was actually 235 milliliters in a year. And then in the placebo group, it was 428. So I remember Jeff Jennings and I having sort of a heated discussion about this because he and I don't agree on this. And first I thought, and I think he's right actually. So at first I thought, well, it's because they gave everybody, if you died, they gave you an FVC of 0, and so it made you look much worse. But when you look at the numbers, not that many patients died. So I don't think it had that big of an effect. So what they're showing is this linear slope, which is again not controlled for, adjusted for age, sex, and height. And that ends up being 100 versus, this is where this 100 versus 200 comes from when they did that. But I don't understand why this looks so different in this study, but in the nintedanib study, when they looked at the slope and then they looked at the absolute change, they were almost identical. So I don't fully understand why that is. And I'm not sure that anyone's really explained, you know, in sort of reading other things about this, no one's really explained. I think what they've done is they have so many other endpoints that they followed that people are willing to sort of go, okay, the slope changed. But I still don't fully understand that. Yeah, do you have a,
the study, did they control for anything when they talked about the slope?
So they did the same adjustment, but when they did their adjustment, they got the same exact numbers when they looked at the average, sort of the mean absolute change over a year per study group. And so I don't understand why that one would be so similar. And the slope, you know, which makes sense. The slope should be about the same as, if it's a year, your slope should be about the same as whatever the absolute loss was, because you're divided by 1.
So it's the controlling for the covariance is what, once you start controlling for things, you're getting a slope for some idealized patient.
Okay.
And that idealized patient is somewhere in the middle of all of your actual patients, and that's why I think that I don't think there's any mathematical reason why this should be the same.
Okay, so it's more just coincidence for the other one, which is fine, which would make me happy, but yeah.
That's how I would.
Okay. The only problem I have is that all the old studies don't look at linear slope. They didn't do any adjustment. They just did the absolute loss over a year. So I don't know how to reconcile that well. Okay, and then this is looking at the mean change in 6-minute walk distance. Again, they have, I think, a lot of supporting data, and I have to admit I was very biased going into the presentation at ATS thinking that they were not going to do anything that convinced me that this drug may be helpful to people, and they did have, I thought, some endpoints that were interesting. So again, less loss in what we look at as sort of functional status or drop in 6-minute walk distance. And looking at patients with their change in dyspnea score, it's not significant. And sadly for both studies, the dyspnea scores, the quality of life scores were not significantly different between the two groups. So people don't feel any better on the medications, which I think is sad. But and maybe if you do get people who are very well preserved, who aren't very limited yet, maybe that's acceptable. Okay. And then looking at adverse events in the ASCEND studies, so rash and diarrhea are the big ones. Was it to the point where the 5% of the patients had to stop the medication? No, but it's similar to the placebo group that about 20% had experienced diarrhea. They don't really look at, and I don't know if it's just because it didn't happen, they don't really look at cardiovascular events, and I haven't had a chance to go back and look at whether they've made some comment, because right now the contacts that I get are about basically like asking me questions about what the other company's study did that people would find questionable. So why wouldn't you look at acute exacerbations? Why would you again look at specific things? So it's a little hard to get I think a clear gauge on this. All right, and then looking again at the capacity ascend, if you're pooling data, you should probably know how the studies are different. So this is looking at the first ones where, again, didn't get FDA approved, and here what they added in. And here they followed for a longer period of time. They treated for a longer period of time, and their primary outcome was at 72 weeks. What they did was they took their 52-week data to do this pooling of data for like the mortality and FVC changes. And then I don't know that there was any other big difference. That's the significant difference. And I think, again, in that the ASCEND trial, the other significant difference is that they were much more strict, that patients had very classic UIP on CT. Okay. So my take on, I guess, both of these studies, I do think that there is, and I was very skeptical when this stuff was coming, when most of it was coming out, that both drugs do have something to offer, but in a very selected population. I do think that the nintedanib has a good argument for FVC stability, maybe a stronger argument than for the pirfenidone study. It may reduce acute exacerbations, but again, how they allowed for definition of acute exacerbation may have hurt their analysis, so it's unclear. The protocol to deal with the diarrhea so that patients can actually stay on the medication, tolerate the medication, is helpful. And then the vasculopathy does make, I think, most providers a little bit nervous. Should we be more aggressive in working up these patients before starting them with stress testing? I'm not sure. For pirfenidone, something still makes me a little uncomfortable about the that absolute loss. And again, it is better to adjust for the covariates, but I'm not sure why it's double what the older studies show. And then there did seem to be better preservation of FVC. So my argument about, because it was deaths and it made the FVC 0, there are only 4 deaths in the treatment arm and 5 in the placebo arm. So that probably didn't change things dramatically. And then, again, in terms of side effect profile, diarrhea like with the nintedanib and rash. And I think, again, for those patients who are coming in who are well preserved, this is something maybe to help with stabilization of disease or slowing rate of loss. But for our patients who have more severe disease, it has not been studied. We don't have a way of reversing scar. It's really that we're not sort of adding to that burden. So once you're past a certain point, I feel that we should not be, and that's, again, personal opinion. There are people who I'm sure are doing this. I don't think that we should be subjecting the patients to this who are already poor quality of life, and sort of, on some level, I think capitalizing almost on desperation. And that's sort of been some of the more recent experiences as this was approved in Canada. I thought one of the pulmonologists out of Toronto made a very good point. She said, it's not like you're going to be better with this. You're not going to get better with this drug, and you still have the disease. And so I think that the things that I sort of think about when I'm talking about patients with this is the side effects. I don't actually try to get too involved with the cost of things because there is a lot of support from there's a couple of different specialty pharmacies. I just got contacted by our outpatient pharmacy to look into kind of who should we be trying, again, to help with getting the drug. So I think that there are ways to help people with the cost of that, and that's something that we should be able to work around. So I don't worry about the cost so much, but again, it's more the side effects and setting realistic expectations with these medications. And so it's still helpful to diagnose a patient earlier, give the appropriate diagnosis. I think those things don't fall by the wayside. My concern when these studies first came out was that out in the community they're probably going to send in less patients for second opinion or to get another set of eyes. And I worry about those patients because what if they have something that's treatable? What if they have I'm seeing somebody that was sent here because he had a non-healing bronchopleural fistula after his biopsy. He was told he has IPF. He doesn't have IPF. He has antisynthetase syndrome. So I think that he has other treatments he can get. So I think that there's still value in that prior workup, and I still worry that patients are just going to be kind of put on this without a lot of, and hopefully with more thought than I'm worried about. Okay, this is actually just a slide comparing head-to-head sort of the different sort of parameters. With that Dejomini patient that I saw recently, her FVC is actually too high for her. She wouldn't have been allowed in the pirfenidone study. So I was like, okay, well, I didn't really look at anybody as high as you. I guess we could use it. But I kind of use it as one of the factors, like, okay, would she have fit in this study or that study? There apparently are a lot more liver disease patients than I realized that have IPF, because there was a time where we saw 3 or 4 in a 2 or 3 week period. And unfortunately, and I've discussed this with some of the hepatologists, unfortunately, patients who are cirrhotic or being considered for a liver transplant cannot go on this medication. And then if they're daily drinkers, they're not going on the medication. And then there's no real screening that's advised except for LFTs. And I wonder if maybe there does need to be another component to that. All right, so looking back at those case scenarios that I was talking about, so in the first, so actually in all the cases I highlighted the things at least to consider. So this first gentleman, he actually would not have been allowed in either study, and probably is not the best candidate for either drug, because potentially cirrhosis. He has a prior history of heavy alcohol use. He also kind of disappeared for 3 years. And I'm all for being involved, but I'd want to get a sense of if he's going to follow up, because he needs monthly labs on the medications. There are ones with side effects that we need to monitor for. So I worry about that. And then his, in terms of his lung function, he's not well preserved enough, and was actually very, just pretty much just at rest by the time he came back to clinic. And then he had just been admitted with an acute exacerbation. So we're not sure of the role of these medications in this patient population. For the next patient, he actually had fairly well, his fibrosis actually wasn't very progressive. His dyspnea and his hypoxia were progressive because he developed pulmonary hypertension. So I'm not sure where you put this gentleman, but I think he sort of fits into a whole other subset of IPF, the patients who have don't have progressive fibrosis or minimal fibrosis and have pulmonary hypertension. Okay. The next one, the one who has cirrhosis, I felt like, okay, that one's at least straightforward, but now Rodeo and I have to figure out if he's somebody that would be a candidate for liver lung, or does this mean he's not going to be a candidate for either, really. And then the next one, who was the former smoker who came in for the IPF therapy evaluation, this is an example of, he had something else. I think he had HP, so we talked about sort of avoiding that and coming back to reevaluate. Although, again, if you ask ILD folks, some of them will just treat them because they're like, give them the benefit of the doubt, try it. And so it's unclear. The next one, the 67-year-old gentleman who's a former smoker with peripheral vascular disease and daily alcohol use. So this is not such a good thing for medication that can cause acute liver injury. And then the peripheral vascular disease, he actually was had recent intervention because he had sort of chronic progressive leg pain because he had arterial insufficiency. So because of that, I thought that he was not the best candidate for the nintedanib. And then because of the daily ETOH, the alcohol use, for either drug. Okay, and then the last one, I actually think if somebody actually can go on the medication. So a 66-year-old female, never smoker, reflux. She actually had well-preserved lung function, but we could see that there was progression from 2 years ago to now. So I don't think that she's just somebody who has stable disease. I think her symptoms do correlate with, we just don't have PFTs from that time to show it, but we have radiographic proof that she's progressing slowly, and so over time. And so we actually were talking about the nintedanib because, when you see these, and I know a couple of you have had to, worked on filling out the form and going through all of this, they ask you to sort of assure that this sort of follows in line with the patients that were in the trial and what you think was best practice. Certainly you might make the argument that if somebody is well preserved and you thought they were a good candidate for pirfenidone and their FVC just happened to be over 90%, why not give that medication to them? I'm not sure. I don't have all the answers for that, but these are sort of the now becoming more daily issues. I thought we weren't going to see another IPF patient for a very long time because of the drugs coming out. But no, I think that there's been sort of, I think, challenging cases, or at least ones where it's more than just looking at the study. It's sort of going through what we think patients can tolerate, if we think it's appropriate, and what our endpoints are for that patient.
Can you say why did you not do to the farmer within?
What's that? I thought he had HP. He was active. If his exposure, and I've changed sort of how I feel about that. If it was remote exposure, I used to say no, this is just burnt out HP. And I think now, because we know that when they look at those IPF patients, a lot of them actually do have prior identifiable environmental exposures that they're not exposed to anymore. And so those patients I probably would consider it, but not active. So in terms of my recommendations, or at least things to consider, please use us. we love going through cases. So that's what it's there for. I think I do certainly sometimes take it for granted that we have this. It is not available, even at most large institutions. It's something that's coming along later. So I do think we're very lucky to have actual chest radiologists and people who are willing to sit down with us for almost an hour every week. I have patients of Dr. Morris's that we've reviewed in the conference and tried to come up with if we were thinking of anything else. We're more than happy to see second opinions, and some people are more comfortable with us taking over, and some people are just want to know what we think, and we do both. And then for me, I still consider comorbidity severity of illness, because this is something that's, again, not going to get them back lung function. It's going to preserve where they are. Counseling of patients. So I think there is still that legitimate desperation. There really is no cure. It's very exciting that we do have medications out there. We don't have a way of improving really their current dyspnea with medication, unless you're doing a palliative approach. I think we have other things we can do to improve dyspnea. And then for research studies, I still bring it up even when I'm talking about these medications with patients, because most of them, the one that we're going to be enrolled in a site for is a fibrogen study looking at a sub-Q administration of a monoclonal antibody to connective tissue growth factor. They had to retool as this became approved, the two drugs became approved, and so they're accounting for patients either being on pirfenidone or nintedanib. So it doesn't mean that you can't be in a research trial as well. We're still, I think, as a community, still hoping that there's more out there. And then in terms of our dyspnea evaluations, and this actually is where I spend a lot of my time. I feel like I'm not so much an ILD doctor, I'm a dyspnea doctor, that we look for the comorbid, because a lot of times patients do get kind of passed off. Oh, it's just their fibrosis. Or fibrosis has been stable for 5 years. They have progressive dyspnea for some other reason. Is it their deconditioning? Is it CAD that's unidentified? Do they have some type of sleep disordered breathing that's contributing? Do they have pulmonary hypertension, reflux, which you all know I'm obsessed with? And so things that we can prevent, preventative care that we still can do for these patients, immunizations, pulmonary rehab. There's exciting data that's coming, and I have to share with Cheryl that actually shows that you do have improvement in dyspnea. That this is something that at 3 months and 6 months you can still see improvements in dyspnea and functional status. And then, of course, palliation. And I think when we're talking to these patients and they're not candidates to be on these drugs, it's usually because they have a severe comorbid illness or they're just too severe. And I think those are the patients that we should be talking about palliative measures, goals of care. And it's hard that first time you meet them. I still don't do it on the first time I'm meeting them unless I think they need to be admitted. We're talking about it, but I think that should at least be something that we're incorporating a bit more. When I went to the Pulmonary Fibrosis Foundation Summit now over a year ago, it was interesting. Most people actually, and I've sort of changed around my practice, that what you have for PFTs are 6 months change in lung function predicts mortality. Most are coming back every 3 months, so that we do address all of these other factors that I think take a lot more time than sometimes just saying, oh, your fibrosis is stable right now, or you're 89, so no, we're not going to do a transplant, but are you walking around okay? So I think that there's hopefully more that we're doing with these patients, and I think it also helps in terms of helping them feel like they still have someone that's taking care of them, even if we don't have potentially drugs to offer, we don't have a cure to offer. I think we also forget sometimes that this disease has a prognosis that's worse than most cancers. And so, again, I think utilizing whatever resources we have for these patients, and I still find it very challenging on a daily basis seeing these patients. It's much easier for me when someone has connective tissue disease or reflux that I can treat and that I can tell them, okay, we have a chance of getting something back. And I can't say that to these patients. And when they're not transplant candidates, I think it's really challenging. So I think that's still a big part of what we need to do for these patients, not just, here's the drug and we'll watch how you do on that. Happy to take any questions. I know we're almost out of time. Yes, Zach Morris.
That was a great summary, by the way. 2 points. One that I have concerns about. In the study, when the ATS, one of the take-home messages I took home from that was that the drug companies for these 2 drugs really stacked the deck in their favor in these drugs, because the first trials that came out that were turned down by the FDA were 2-year trials. These recent studies showed the same effect at 1 year that those did.
That's just pirfenidone, not the BI study. The BI study, their phase 2 was a shorter duration. But yes, I see what you're saying.
Pirfenidone went out 2 years, but the difference completely washed out at 2 years. So when they intentionally did these studies of 1 year, stopped at that point to see the same results. So the jury's still out at 2 years, and these things don't really make a difference in my mind.
And there's actually data from Japan that preservation and lung function may be lost in that second year of being on profenadal because it's been approved there, so they have much more experience.
So they're the second group to say that now too.
Mhm.
And then the second thing is as far as, I've got 4 or 5 patients now since these been approved. I've tried to put on these drugs.
Mhm.
Now here's the interesting dilemma now, because these are patients different than downtown. These are patients with insurance out there. They're, guys work in the motor company, so they're not rich, but they have good plans and stuff. Well, anyway, the insurances are all approving these drugs really easily. But the problem is the co-pays are like $1,500 a month.
That's where
And
getting
then-
the specialty
right.
pharmacy help.
And that's where we're actually getting these other people
Yeah.
involved now, but the drug
Absolutely.
companies they're not cutting these patients any slack. They're just saying the patients have to turn in their W-2 forms, their income tax forms. As soon as they see what their real income is, and they're not rich, they're automatically excluded. And they actually said you have to be below a Social Security income for us to give you any assistance. These people aren't gonna pay for these drugs, that much, 12, 15 grand out of
Right.
pocket for this little bit of benefit. So,
Right, each one is about $90,000 a year.
94,000,
Yeah.
right?
Jesus.
Yeah. Yes.
So, if you have a new patient with a new diagnosis, so you still don't know what to do until 6 months, you hit the 6
No,
months?
I think if they're well preserved, there's
Because you started 6 months
there's
in both.
there's data for looking at sort of predicting mortality in patients. It's called the GAP index. It looks at their gender, age, gender, and where their FVC and DLCO are to begin with. And they're looking at whether there's longitudinal value to that score over time. If you check it again next year and it's worse, probably means the patient's not going to do as well. But I think when first having that conversation after you establish that diagnosis, I think it should be part of the discussion. And if you don't think it's a good option for somebody, why going through that rationale? Because they're gonna, the first things they look up is that they look up on the internet, they see the 3 to 5 year, and now actually higher on there are FDA approved medications.
So, you don't try steroids at all? You just,
If the diagnosis, if I'm clear on the diagnosis of IPF and they're not an acute exacerbation, I do not.
do you have to stop the steroids to give that?
Again, it's how it's going to be in practice, but again, we know that steroids in sort of a maintenance treatment of IPF doesn't have a role. That patients don't improve on that. It doesn't help preserve lung function. We usually give them more the comorbid illnesses with it. As Angel Kaz used to say, we made that patient fat. We would give them steroids. Yes.
Several patients of mine, not for this disease, but they're on the internet, and the internet thing now is stem cell transplant for something crazy. Do many of your patients actually?
I've had some that ask about stem cell, and there are investigational studies looking at stem cell transplant. Certainly, it's better established in autoimmune disease, but I do think that's part of the next wave. I think the other thing that will be happening, hopefully soon, is that we'll take some of the data that we have on what sort of looking at sort of biomarker profiles for who would actually be a more rapid progressor. It's more genetic data right now. So who should actually be on these drugs? Who actually benefits from the drugs? But yes, the stem cell stuff is coming up. Yeah.
Do we know, since they excluded patients that they thought were going to get transplanted within a year, do we know that if there are any complications due to the mechanism of action of the drugs in healing once somebody does go for?
So for both,
a
you actually
surgical
have to
procedure?
stop. You stop them. For the nintedanib, it's like if you think surgery is going to happen in the next 3 months. So if they're listed, and let's say, because we know the things that bump up their score is the hypoxia part. If they're getting much more hypoxic, then first they're probably progressing on the drug. And it's unclear what to do in that. I tell the patients up front that if you progress on this, we're not leaving you on this. It has side effects. If it's not working, then why are we going to leave you on this? So I have that idea implanted already. And people may have different take on that. Yes.
Kristen, since we don't know the mechanism, anybody looking at using them together?
So that's coming, I think.
$180,000.
I do think that's coming, and then I think we'll get from the ongoing research studies now looking at other therapies. It's going to be like profenadone plus this. I talked about the monoclonal antibody, or nintedanib plus this other one. They'll probably get some idea of that. But then I do think at some point they are going to do. There's talk of them doing a study together. There's nothing official though. of giving both drugs.
Yeah.
They can affect the same pathways, but they work in different ways. I think the concern would be more the LFT stuff. Would be my own concern with going on it. But
It's interesting,
Yeah.
and just sort of on a side note,
Yeah.
and you may have seen in the press, a lot of what the oncologists are now doing about drugs that are outrageously expensive and of minimal benefit, and sort of pooling together to say, we're not gonna use this drug because we don't think it's really reasonable to ask our patients to pay this kind of money for a drug that has minimal effect, and we may be getting there ourselves. Because I mean, it really is hard to argue that you should pay $100,000 for a 100 ml change in an FVC.
Yeah, and so they've how it's
And you
been
don't
billed
feel
to
better.
me. Yeah, oh,
Right.
sorry. Yeah, how it's been billed to me when I talk with the pharmaceutical people, which I hate doing, but I have to do, is in terms of all the different aid programs that they have. But again, I've not had where everything goes through and the patients wanted to be on it yet. So Sarah and I have someone who's probably gonna go on the medication, but on one of the medications. But it's there's supposed to be a lot of aid for that, and if they get told you still have a high copay, you're supposed to actually just say no, you don't accept that, don't pay the copay, and we're going back and we'll, again, certain specialty pharmacies and the drug company is actually supposed to be helping with those, is the pledge that they've given.
The drug
So,
companies line out, because
yeah.
I've gone to both companies now on multiple patients, and they've actually even admitted on the phone to me, well, the only way we really help is a patient really is like below social security income, they really gotta be in a hardship case.
Well, if they do like they do for Actar gel, if I prescribe Actar gel for a patient and they agree with my notes and stuff that the patient may benefit from it, if the insurance company cover it, the people who make the Actar gel will just give it to the patient.
And I think
No copay, no nothing, just give it to them.
They're doing limited time free, but then when they do the limited time free, they'll say, we want to make sure that you can actually get the drug after. So they'll actually run whatever they can to check on that.
Yeah.
I think we're done here. Thanks, everyone.
Very good question.
Tricia, press F10